a patient we saw in our interstitial lung disease clinic. I do not have any conflicts of interest, and I'm a pulmonary critical care fellow. So this was a 61-year-old man with a history of sleep apnea, hyperlipidemia, rheumatoid arthritis that came into our ILD clinic with dyspnea on exertion for 3 years. And with that slow, insidious onset in our clinic, that almost always means this is somebody with pulmonary fibrosis or cellular NSIP, something like that. So he was a 10-pack year smoker, but had quit 30 years ago. And for his history of rheumatoid arthritis, he'd previously been on methotrexate at a dose of 15 milligrams a week. And he's also been on infliximab, 400 milligrams every 4 weeks before that. And the reason to us that those dosages are significant is that certain types of interstitial lung disease, as you guys know, can also be caused by these agents as well, at least methotrexate. So on physical examination, he had dry crackles, no presence of synovitis, and rheumatoid factor and CCP were negative, which I think had occurred after being on therapy. His ANA was positive in a diffuse pattern, and he had a negative SSA, SSB, and RNP. So we do what pulmonologists do, and we decided to get a CAT scan on this patient, given his basal or dry crackles. You can see in the right upper image there, that's the apex of the lungs. There's this central consolidation with some ground glass opacities. And then the larger section that I have here is a lower lung cut. And there's kind of subpleural dense consolidation with, as you get more central, more ground glass present, the presence of mild air bronchograms. And suffice it to say, although you can't see it on this image, there was no traction bronchiectasis present in this patient. So we did a bronchoalveolar lavage, and this was consistent with 84% alveolar macrophages, which is the expected result of a normal BAL. So we felt that the BAL probably wasn't telling us the full story because we could see the burden of lung disease here. So at this point, our differential, this isn't radiographically concerning for idiopathic pulmonary fibrosis, so we were thinking more about cellular NSIP, also cryptogenic organizing pneumonia. And of those, the one that would be easier and probably safer to treat at the time would be the cryptogenic organizing pneumonia, also known as bronchiolitis obliterans, so organizing pneumonia. So we treated with 60 milligrams of prednisone daily for a month, and the patient did not improve, and radiographically didn't improve either. So we admitted the patient to our hospital for a wedge resection and surgical lung biopsy. As you can see here in this image in the right upper, this is a high view, kind of a high altitude view. You can see the patchy areas involved. Then zooming in, you see this mucinous gland-like formation, which was concerning for invasive mucinous adenocarcinoma. EGFR testing was negative, ALK-MET and RET were negative. The patient was KRAS and SMAD4 positive. And after the biopsy, which we see sometimes in these people with diffuse interstitial changes, the patient was admitted to our intensive care unit, developed ARDS, and unfortunately passed away. But I think this is a good case, and everyone in this room is aware, adenocarcinoma is the most common type of non-small cell lung cancer, and I had to remind myself that these people often have little or no smoking history, as in this patient's remote smoking history. And rarely these cases can present with this diffuse interstitial pattern. And I also saw in the literature review that KRAS mutations are more commonly seen in these current former smokers. And also there is an association with invasive mucinous adenocarcinoma. I saw that other patients that had a better performance status than this patient had been treated with cisplatin, pemetrexed, and bevacizumab. And in larger centers, we have a transplant program, but in larger centers that can enroll more sick patients, I have seen bilateral lung transplant used in case reports. So that would be something for us to consider again in the future in this patient had he wanted to be more aggressive. So I think from the future in our interstitial lung disease clinic, I'm going to consider invasive mucinous adenocarcinoma a little more high on the differential and consider surgical lung biopsy more often in this setting. I'd like to thank you for your attention. I'm happy to answer any questions.